This is the lecture on intrapartum nursing, or labor and delivery. So oxytocin is a mammalar hormone that acts like a neurotransmitter in the brain. And when this is released in large amounts with cervical and vaginal distension during labor, this is what facilitates labor. It's also following stimulation of the nipples, as we know, facilitates breastfeeding. So the baby pushes against the cervix, causing it to stretch. The stretching of the cervix causes nerve impulses to be sent to the brain. Then the brain stimulates the posterior pituitary to release oxytocin. The oxytocin causes smooth muscle of the uterus lining to contract. And then again, that pushes the baby against the cervix, causing it to stretch. So it's a very cyclical functioning with oxytocin. There are different stages of labor. There are first, second, and third, and fourth stage of labor. The first stage is the time of the onset of true labor until the cervix is completely dilated, which would be 10 centimeters. The second stage of labor is the period after the cervix is dilated to 10 centimeters and until the baby is delivered. So from the time she's complete or fully dilated till the baby is delivered. The third stage of labor is the delivery of the placenta. And the fourth stage begins with the delivery of the placenta and ends 4 hours after delivery. In the first stage of labor, this is the longest stage, and it involves 3 sub-phases, if you will. There's an early, or what we call latent labor phase, there's an active labor phase, and then there's a transition phase. In early labor, it's the time of the onset of labor, so when mom starts to go into labor, until the cervix reaches a dilatation of 3 centimeters. In the active labor phase, this will be the continuation of the cervical dilatation from 3 centimeters to 7 centimeters. And then the transition phase will continue from 7 centimeters until the cervix is fully dilated at 10 centimeters. So those are the 3 phases that are in the first stage of labor. In early labor, this can last approximately 8 to 12 hours. The cervix is effacing or thinning. The cervix is dilating, hopefully to 3 centimeters. Contractions are lasting about 30 to 45 seconds long. They're still pretty irregular at 5 to 30 minutes apart and are typically mild. This is a good time for some patient education and discussion on what to expect, as they're not terribly uncomfortable or in pain, and they can pay attention to education. In the active the active phase of labor, this is the continuation of the cervical dilatation from 3 centimeters to 7 centimeters. This will last about 3 to 5 hours. Contractions are lasting now about 45 to 60 seconds long, and they're a little bit closer together. They're about 3 to 5 minutes apart, and the contractions will definitely start to feel stronger and get longer. She's a little more self-focused at this time, so she's really not going to be listening to a lot of education at this point. You're just here to support and guide. This is also a good time to offer an epidural. The ideal time to get an epidural is between this 3 and 7 centimeters, if that's what the patient wants. In the transition phase, this is the continuation of dilatation from 7 centimeters until the cervix is fully dilated at 10. This will last a short period of time, anywhere between 30 minutes to 2 hours. The contractions will be longer. They'll last 60 to 90 seconds. They will be more frequent. They'll be every 30 seconds to 2 minutes apart, and they are very long, strong, and intense at this point. This is a period of time where we call a crisis of confidence. So if you have a patient who's going natural without any kind of analgesic or anesthesia on board, and this is the part where they're feeling the most intense contractions, this is the time where they usually either panic or feel like they need to give up because it's so uncomfortable at this point. So this is called the crisis of confidence. There's limited patient-nurse dialogue, and you'll get very short answers from mom or none at all because she's very self-focused at this time. In the second stage of labor, this is the period of time where the cervix is now 10 or fully dilated and the baby is delivered. During this pushing phase, while mom's pushing this baby out, her contractions will be about every 1 to 2 minutes, lasting 60 to 90 seconds long. They'll be very strong. And there'll be an involuntary effort to expel the fetus. So although she is doing pushing, she will involuntarily do some pushing to expel this fetus that her body will just take over and want to do. This can take 1 to 3 hours depending on whether or not this is her first delivery or if she's had many before. In the third stage of labor, this is the delivery of the placenta. The average time can take up to 30 minutes. Usually just a few minutes after the delivery of the baby will the placenta start to detach and deliver, but we can give them up to 30 minutes for this to happen. The physician can help assist by gentle traction of the cord. They don't want to pull. And we know that the placenta is ready to separate because the umbilical cord will lengthen, the abdomen will involute, there'll be a gush of blood, and those are all signs that the placenta is now separating. Maternal physical and emotional relief will occur because the labor is over. She will be both excited and focused on the baby, and fatigue will set in quickly. The placenta, we know, has organ functions that are metabolic. They transfer the substances between mom and baby, and endocrine. There are two sides to the placenta. There's a fetal side, so the side that the baby would be up against, which is shiny and smooth, with branching vessels covering the membrane. We call that the Schultz side. Then there's a maternal side, which is the side of the placenta that is connected to mom's uterus. This is rough where it attaches to the uterus, and we call this the Duncan side. So there is a little thing that students will do to try to remember this. They'll say shiny Schultz, dirty Duncan, because they'll describe the different sides of the placenta. The umbilical cord is inserted on the fetal side, near the center, so the Schultz side. And it's fully developed and takes over at about 8 weeks of pregnancy. So a term placenta, this is what it would look like from the fetal side. You can't tell greatly from this picture, but this would be shiny. This is where all those branching vessels are seen. The cord is inserted toward the center on the side of the Schultz side, and then this is the umbilical cord here. This is the side, or the Duncan side of the maternal side. It's much darker and rougher because these are where all those blood vessels attached the placenta to the uterus. The fourth stage of labor starts with the delivery of the placenta and lasts for about up to 4 hours afterwards. This is the recovery phase of delivery. Her uterine contractions are no longer contractions, but more of cramping, and this is what's helping to prevent the bleeding. It happens right away after the placenta is delivered. She's both excited and fatigued, and will need close, continuous monitoring to make sure that she's not having any issues with postpartum hemorrhage, and we're keeping a close eye on her vital signs. In labor, we know that labor usually starts around 38 to 40 weeks of gestation of a pregnancy. And there are various factors that may cause labor to start. There's different theories to it. There's theories called decreasing progesterone. There's a prostaglandin theory, a stretching uterus theory, an oxytocin theory, and a placental theory. So we're going to go over those right now. The uterine stretch theory means that there's pressure on the uterus from the growing fetus, and that's what's causing the uterus to contract, and that's why labor starts. There's the oxytocin theory, which is the one picture I showed earlier, where the pressure of the fetus on the cervix releases oxytocin from the posterior pituitary gland, and this is what causes the uterus to contract and to go into labor. In the progesterone deprivation theory, when we know that progesterone is originally high in the pregnancy, which is what's stopping the uterus from contracting, we know that toward the end of pregnancy, there's a flip in the hormones where progesterone becomes low and estrogen gets high. So if there's less progesterone, it's more likely that the uterus is going to start to get irritable and contract, as well as the increased estrogen makes progesterone less effective. The other theory, the prostaglandin theory, is that prostaglandins are released from the placenta, the forebag of the placenta, and that plus the decreased progesterone is what's causing the synthesis of these prostaglandins, and they are what's causing the uterine contractions. And then the last theory is the placental theory, or what we call the aging placenta theory, which is just that the increased age of the placenta, meaning the closer to the end of the pregnancy, there's a decreased blood supply to the baby, and that may be what causes uterine contractions and labor. So this is the ones that I just went over with you guys, the different theories of labor. And now we're going to talk about the premonitory signs of labor. How do you know you're going into labor? Well, we talked about lightning and how that is the movement of the baby down into the pelvis. So you might notice that you can breathe a little better, or that you can have a little bit more room to eat. You don't feel so full, but that's the baby dropping. You might experience Braxton Hicks contractions. You might see some cervical changes. If a practitioner does an exam, they may notice that you are now dilating or effacing. You may have a bloody show as the cervix is changing. You could have your water break, the rupture of membranes. Some women experience a burst of energy, or what they call nesting, where they all of a sudden are preparing for delivery by cleaning the house or preparing meals. You may notice a weight loss towards the late stages of pregnancy, getting into labor. You might have urinary frequency as the fetus is now laying basically directly on that bladder. You might notice an increase in backaches or sacroiliac pressure. You may experience some diarrhea or even nausea or vomiting, and you may notice the loss of your mucus plug. So there are differences between true and false labor. So true labor means that the uterine contractions that you are experiencing are causing cervical effacement and dilatation. And those contractions are usually long, strong, and intense. And the location of the uterine contractions usually wraps from back to front. And ambulation will not change the intensity. So just by moving or changing position, it will not lessen the intensity. Whereas in false labor, you can contract, although no cervical change is taking place. Those contractions may seem irregular or mild, and ambulation can sometimes lessen the contraction strength or stop them altogether. So oftentimes if a mom is not sure if she's in true labor or not, we will tell her to take a walk and walk around a little bit for an hour and see if that made a difference in those contractions. If she's in the labor and delivery unit, we will check her cervix initially, have her walk that hour, and then recheck it again. And if there's no cervical change, it's likely a false labor. There are the 5 P's of labor, and those stand for passageway, passenger, power, position, and psyche. The passageway is the bones of the maternal pelvis, sacrum, and coccyx. It also includes the soft structures like the cervix and the vagina, and the size of the maternal pelvis is measured in diameters of the pelvic inlet, mid-pelvis, and outlet. So there are different types of maternal pelvises. There is the gynecoid, the android, the anthropoid, and the platypoid. So the gynecoid is the ideal pelvis shape, and it's what at least 50% of women have. And that's the ideal shape for delivering. The platypoid is more of like a kidney shape, and this is difficult for the head to engage. So if a mom had this shaped pelvis, this would make her labor and her delivery difficult. The android is the male type, which is slightly more difficult for labor and pushing due to its heart shape. And then the last one is the anthropoid, which this is more commonly occurs when you have a breech baby, because the baby's head cannot fit into the lower part of the pelvis. So we don't know what mom's pelvic type is when she first gets pregnant or before she delivers. We wouldn't know that without an x-ray. So a lot of times we just have to do a diameter check with a pelvic exam with the hand to try to measure if this is a big enough outlet for the baby to come through. So again, the different explanations to the pelvic shapes are there. The next thing we want to talk about when we talk about labor is a Bishop score. A Bishop score is a score that we assigned to see how likely she is to either go into labor or how likely she is to be successful if we were to induce or augment labor. And we look at cervical dilatation, effacement, the fetal station or how low the head is into the birth canal, cervical consistency, as well as cervical position. You do not need to memorize this table. I just want you to get an idea of what we're looking at when we refer to Bishop score. And obviously, the higher the score, the more likely you are to either go into labor soon or to be successful as an induction. The second P stands for passenger, which is our baby. And this has different variances to it as too. The size of the baby makes a big difference because the larger babies have a more difficult time being delivered than a smaller baby. what we call a fetal attitude, which is the relationship of fetal parts to each other, the flexion of the baby, the extension, the lie, the presentation, the position, the engagement, and the station of the passenger. So when we look at the fetal head, we're looking at the bipyramidal diameter, the bitemporal diameter, the occiput frontal, and occiput mental. And we're looking to see that greatest diameter of the fetal head to see if it would fit into the normal size pelvis. So the greatest diameter of the fetal head would be that bipyramidal measurement. When we're looking at the bitemporal and the occiput frontal, we're looking at both the nose and the prominent part of that occipital bone. And when we're looking at the occipital mental, we're looking at the greatest diameter between the temporal and the sutures. So when we're doing a pelvic measurement, this could be used to determine if the bony pelvis will seem adequate enough to permit a vaginal delivery. And you can see this cross-sectional view where we kind of take a measurement using our hand of these diameters to see if the head would fit properly through this bony pelvis. When we talk about a fetal lie, we're talking about the relationship of the longitudinal axis of the fetus to the longitudinal axis of the mother. So the longitudinal lie would be when a baby is lying up and down, so like vertical or they can be head down, and that would be vertex, or they could be head up, which would be feet or buttocks down, which would be breech. That's a longitudinal lie, the up and down. A transverse lie would be if the baby lies laterally across the uterus. An oblique lie would be if the baby's lying diagonally. So this is a picture of a longitudinal lie in a vertex position, so just straight up and down with the head down. This is an example of a transverse lie where the baby's lying across the uterus. And if it were an oblique, it would be in a diagonal. The presentation refers to the fetal part that enters the maternal pelvis first. So in a vertex position, we're hoping it would be the cephalic or the head. But they may not be fully flexed properly, so you may notice that their face is coming out first, or their brow, or they may be in a breech presentation, which would be their buttocks or a foot. They could be a shoulder presentation where the shoulder is coming out first, or they could be in a compound presentation, which is their head plus usually a hand or something on top of the head that's both trying to come out at the same time. So when we talk about vertex fetal lie, we're talking about flexion versus extension. You want the baby's head to be flexed. Notice the chin is against the body, and in this flexed, tucked position is the ideal way to deliver. If the baby's head is extended, this is what would cause a face presentation or a brow, and this would make it difficult for a vaginal delivery. It could cause injury to the infant, and it will sometimes cause the mom to need a cesarean section. Fetal attitude has to do with the amount of the degree of flexion that the baby has in the vertex presentation. So they can be a vertex, which is that completely tucked position, military, brow, or face. So these are examples of those. So in a vertex with complete flexion, we're looking at the perfect position to deliver and the tuck. And this is just a view of the head from looking from like straight on into the pelvis. Military presentation, they have moderate flexion. So notice that their chin is not completely tucked to the chest. Partial flexion would be what we call a brow presentation, because what you're seeing as your presenting part is the brow right here. And then a face presentation, which would be full extension, would be where the face is the presenting part due to the amount of extension. In a breech presentation, you could have 3 different types of breech. You could have a frank breech, where the legs are straight up in a pike position. You can have a full, or what we call complete breech, where the baby's sitting with their legs crossed and their hips extended. Or you could have a single or a double footling breech, where one foot or both feet are trying to come out of the pelvic opening. Now, in the cases of breech, we don't usually deliver a breech presentation vaginally. However, if a mom has delivered a baby before and have what we call a proven pelvis that she can handle a delivery of an infant, sometimes doctors will allow her to try. However, if this is a first-time mom or a big baby, they will not allow a breech vaginal delivery. And the only one that they will even attempt to do vaginally is the frank breech. They will attempt to deliver this one vaginally. They will not do it with the full. They will not do it with the footling. These two require a cesarean section. Now, in this case, they can try to get the baby out vaginally because it's in this kind of streamlined piked position, but there is an increased risk of the cervix closing around the neck once the soft part of the body, the buttocks and the thighs and the abdomen, are delivered. And then the hardest part to get out, which is the head, which didn't have the benefit of any kind of molding in the pelvic structure, could get caught. And that is the high risk of the cesarean or the vaginal delivery with a breech presentation. Now, if you have a baby who's breech, you have the option that your physician may recommend called a version. So an external version promotes vaginal birth by changing the fetal presentation from a breech or a transverse lie to a cephalic lie or a vertex. And we do this by simply turning the baby externally. So the doctor would put an ultrasound on mom to make sure that he has the positioning of the baby correctly, as well as we're getting an adequate heart rate. And the doctor may give the mom something for pain or something to relax her uterus. And then he or she would then turn the baby by using that Leopold's maneuver to figure out where the head and the rump are, and simply try to turn the baby from the outside, making the baby do a somersault so they can get into a vertex position. An internal version is something that's used specifically if you're having twin deliveries or multiples. After the first baby is born, they can sometimes go into the uterus internally and turn that second or third baby around, do a version internally to get that next baby to come out vertex. So this is a picture of an external cephalic version where they're grabbing from the outside again the head and the rump, and they're trying to turn that baby into the somersault position in the way that they're faced. Obviously, this is done in the hospital. It's done under ultrasound, as well as they have IVs running, medication given, and if this becomes an obstetrical emergency, which it can sometimes do if there's a cord accident or compression of the cord that causes fetal distress, they have what's called a double setup, meaning they have a C-section room ready to go in case this were to turn into an emergency C-section. So obviously, doctors will not attempt this until toward the end of pregnancy in case they have to deliver this baby due to any complications from aversion. So the fetal position is the relationship of the fetal presenting part to the maternal pelvis. So when the baby is in a vertex or a cephalic position and presentation, the way that their head or body is turned will give you different fetal positions. And these are some examples down here. So fetal position is determined by first figuring out which side of the maternal pelvis is the fetus towards. So, and we're talking about the back of their head, not their face, but which part of the back of their head. So is it toward mom's right leg or her left leg, or right side of her pelvis or left side of her pelvis? The second thing we determine is, are we looking at the occiput, which is the back of that baby's head, the mentum, which is more like the forehead, or the sacrum if they were in a breech presentation. And then the third indicates the relationship of the landmark of the fetus to the front, back, or side of the pelvis, meaning is the baby's occiput toward the anterior, posterior, or is it transverse? And examples would be what we call ROA or LOP. So we would say right occiput anterior or left occiput posterior. Those are examples. So we're going to go ahead and look at some pictures to help you make more sense of this, because this is a difficult concept to figure out. So this is a baby who's in a right occiput position, right occiput posterior position. This is a baby in a left occiput posterior position. This baby's in a right occiput transverse position. This baby's in a left occiput transverse. And then this baby is in a right occiput anterior position, and this one is in a left occiput anterior position. So we're going to look at some pictures and we're going to practice. So first of all, when we're looking at the pelvis, this is obviously mom's pelvis. This is the baby's head coming out in the vertex position. When we talk about occiput, we're referring to this part right here. So here's your frontal, your anterior fontanelle. So it's going to be the opposite of the anterior fontanelle. It's going to be this occiput right there. So when we're looking at that, we're going to say that that picture was direct occiput anterior. And how do we know that? Well, first of all, the occiput is direct, meaning it's neither toward her right nor her left, and it is toward the anterior, so the top of her pelvis. So we would call this position direct occiput anterior. Now in this position, here is our occiput, right? This is mom's right side of her pelvis, her right leg, and her left. So if we look at the answer for this, this would be the right occiput anterior. And if we go back and look, the occiput is toward the right side of her pelvis. It's toward the anterior or the top of her pelvis, and this is the occiput. So this is where we get the ROA. So in this picture, we're looking at a baby who's turned differently. Now the occiput is where? The opposite of the anterior fontanelle, so back here. So the occiput is toward mom's right side of her body, but it's toward the posterior part of her pelvis. So this one would be right occiput posterior. In this picture, the occiput is now toward the left side of mom's pelvis. And the occiput is again posterior part of the pelvis. So this would make baby a left occiput posterior. And then in this case, this baby's occiput is on mom's left side, but it is neither anterior or posterior of her pelvis. It's in a transverse lie. So this would make a left occiput transverse position. And then here's another one where the occiput is toward mom's left side and toward the anterior part of her pelvis. So this would make it a left occiput anterior, and this is the most common position for our babies to deliver in. When we talk about engagement, we're talking about when the largest diameter of the presenting part reaches the pelvic inlet and can be detected by the vaginal exam. So when we go into the inlet of the pelvis and we can feel the baby's head, we are now in that part of the pelvic where we can reach it by vaginal exam with your hand. And we can either say that the baby is floating or ballotable or engaged. Floating means that the baby is not in that pelvic inlet yet and it's still floating in the uterus in the amniotic fluid. Ballotable means that they're in the pelvis and I can now touch the head, but it's not stationary there. So if I were to push against the baby's head would float off my finger and then come back down onto my finger. If they're engaged, the head is now not stuck, but secure in the bony prominences of that pelvis inlet, and it's not going anywhere. So if I were to push on that baby's head, I could not get it to ballot off my finger. Station is the relationship of the presenting part to the ischial spines of the maternal pelvis. So in mom's maternal pelvis, she has these little bony prominences called ischial spines that can be felt on a vaginal exam. And we measure the baby's head as it's moving down the pelvic structures by these little bony prominences as our landmark. If the head is above these bony prominences and it's high up here, we call that a -3 station. Well, a little bit lower is -2, a little bit lower is -1. When they're right at the ischial spines, they're at a 0 station. Once they surpass the spines, they can go to +1, +2, and +3. And that's when you're seeing that the head is now crowning. Keep in mind this is just a subjective data. It's not anything that we can actually measure, but that we can determine by feel and by practice from doing this. The next P we're going to talk about are the power, or what we call forces of labor. And there are primary and secondary powers. So the primary force consists of the involuntary contractions of the uterine muscle. So those are contractions that you have no control over. And contractions and increment, acme, decrement phases, and resting phases. So when we refer to the contractions, we're talking about the primary involuntary force. We're talking about the frequency, so how often they're occurring, the duration, how long they last, and the intensity, how strong they are. These are contractions that are causing the cervix to efface and dilate. In a prima gravida, a first pregnancy, the effacement will take place first, so the thinning and the shortening of the cervix will happen first, and then the dilatation. And in a multigravida, they'll do both at the same time. So this is an example of what a contraction would look like on a monitor. We talk about the frequency by counting the start of one contraction to the start of the next, and that would be the frequency. Keep in mind these are 1-minute intervals on this electronic fetal monitor paper. So we would count, the start would be 1, 2 minutes, and then we start another one, and we'd say 1, 2, and we start another one, and then we continue counting. So we'd say those contractions are 2 minutes apart. Now the duration would be the length of how long it lasts. So from the start of the contraction to the end of the contraction. And it's not on this paper here, but on normal fetal heart rate paper, there's 10-second blocks in here, and we would count the duration. So in this case, this duration would last 60 seconds. And the intensity would be how strong this contraction is. Now, if they have an external monitor, it does not tell the strength of contractions. It just tells us how often they're occurring and how long they last. But things can interfere with telling the strength, meaning that adipose tissue or position of mom or position of the monitor on the belly doesn't tell you a true intensity. The only way you can tell intensity when they have an external monitor is if you palpate the uterus and feel how strong it gets. And a good rule of thumb is that a mild contraction will feel like what your nose feels like. A moderate will be what your chin feels like, and a very strong or intense contraction will be the what your forehead feels like, so as hard as your forehead is. If you have an internal monitor, which we'll talk about more in the next few slides, that will tell you an accurate intensity measure of how strong that contraction is. And when we talk about the contraction increment, which is the ascending part of the contraction, the acme, which is the peak, and the decrement, which is the dropping of the contraction or the relaxing of the uterine muscle. And then the interval is the break that the uterus takes in between the contraction before it starts its next one. In cervical change, we know that effacement needs to take place, which this is the thinning or the shortening of the cervix. And we call this between 0 and 100% effaced. So 0% effaced means that it's still thick and not short. It's still long. And then if it's 100% effaced, that means it's completely thinned and completely shortened. When we talk about the dilatation of the cervix, we're talking about the opening of the cervix. And remember, it initially starts closed or 0 and goes up to 10 centimeters, which is complete. And the ketchup versus mayo bottle example is just another way to visualize this. Whereas if you think of a glass ketchup bottle where the neck is long and the opening is a small hole, then you think of a mayonnaise bottle where the opening is now a wide mouth opening but a very short, almost no neck. That's exactly what happens to the cervix. The length of it shortens and the circumference of it widens or dilates. This is a really good YouTube video that I'd like you to watch, which is another visual representation of what occurs during dilatation and effacement. A secondary power is that consists of the voluntary use of abdominal muscles during the second stage of labor to facilitate the descent and delivery of the fetus. So in turn, this is the pushing part. The position is another P that we're going to talk about, and this we're referring to maternal position. Or position changes. We're not talking about baby's position. This is maternal. This can facilitate the descent of the fetus into the birth canal. It can allow comfort for mother, and it can increase uterine blood flow or perfusion to the fetus. So we are constantly changing mom's position. We are encouraging ambulation, rocking, moving from side to side, sitting on a birthing ball, rocking in a chair. All of these things will help facilitate the descent of that fetus into the birth canal. It also can give her comfort if she's having particular pain in her back. And it also, remember we talked about just going from side to side will help with uterine blood flow because we don't want mom laying flat on her back. And then the last P is the psyche, which is the psychological component of childbirth, which includes excitement and fear, anxiety, and a perceived loss of control. So when we talk about cardinal movements, and we're talking about this in the cephalic presentation, we're talking about the 7 cardinal movements that a baby does as they're moving into the birth canal. There's engagement, descent, flexion, internal rotation, extension, external rotation, and then expulsion. And there's another little thing that students will sometimes use, and it's every darn fool in Rotterdam eats egg rolls every day. And it just kind of helps you get the order of which that 7 cardinal movements happen. So this is an example of what we're talking about with 7 cardinal movements. And it's the way that the head will start to descend as well as rotate before it's completely expelled out. This is a very good video as well to watch on how the baby descends into the pelvis, rotates, and then expels out. So I would encourage you to watch this video as well. So when we talk about maternal physiological responses to labor, we're going to talk again about the different body systems. So in the cardiovascular system, the cardiac output we know is significantly increased during labor. It's doing a lot of work. The blood pressure will increase during uterine contractions. So if you're taking a blood pressure, make sure you're doing it during the interval part, the part where they're taking a rest. Pulse rate can increase during uterine contractions, and you want to make sure you're taking vital signs during resting period and not during a contraction, which can amplify all her vital signs. In fluid and electrolyte imbalance, she's going to definitely be sweating, so she's going to have diaphoresis. She'll also have loss through breathing because she's doing, sometimes a hyperventilated type of breathing, and increased muscle activity. Her respiratory, her oxygen demands and consumption will increase. It'll vary from a metabolic acidosis to a respiratory alkalosis and then return to normal in that fourth stage of labor. And remember, 50% is increased of oxygen that's used by the placenta. In the renal and gastrointestinal, she may see polyuria. Her gastric motility and absorption will decrease, which is one of the reasons why we don't feed mom in labor, or we encourage them not to eat big meals if they think they're going into labor. Because that gastric motility is slowed down, she's likely to throw up whatever she tries to ingest. Food will remain in the stomach long, and the patient can vomit that up during that transition phase. So we only really offer ice chips during labor to help hydrate her, but it also digests differently in the stomach and doesn't cause her to get nauseous with that. And then another reason why we don't feed during labor is that anyone who's laboring is always a potential for surgery, always a potential for a C-section. So you certainly don't want food sitting in the stomach because you have a risk of aspiration if we were to have to put that patient under a general anesthesia in cases of emergency. In the immune system, her white blood cells will be increased to about 25,000 to 30,000 during labor. In the nervous system, obviously she's experiencing pain, all types and in different locations, and those are different factors that will influence her pain perception. The fetal response to labor, well, the heart rate will stay between 110 and 160 beats per minute. The CO2 increases and the pH decreases, giving it a slightly acidotic pH. As far as pain management goes for the intrapartum period, you can do non-pharmacological methods of pain management. That would be positioning of mom, changing her position, different breathing techniques like Lamaze, relaxation techniques. There's something called a gate control method, which is the control theory to explain why massage or touch can be helpful during pain management strategies like childbirth, because the touch increases large fiber activity and has an inhibitory effect on pain signals. So meaning that if she is getting a back massage, she's more likely to experiencing that feeling over the pain she's feeling somewhere else, and it kind of gates it or gates it off, if you will. Hydrotherapy, if she wanted to get into a hot shower or a bath, a lot of the hospitals offer birthing tubs now where women like to labor in that. And then some women try hypnotherapy as well. If you're using a pharmacological method, you can have an analgesic. An analgesic agent will decrease the amount of pain that's perceived. The goal is to maximize pain relief with minimal risk to the fetus. So remember, if you give too much of these analgesics, it can cause respiratory depression in the neonate when they're first born. Those medications would be like Nubain, Dilaudid, morphine, Tylenol, Percocet, and then even some Phenergan or Reglan can be given for nausea or vomiting. We can give her anesthesia. So if it's given too early in the labor stages, it could slow down the progress. So if we're giving anesthesia, we typically give what's called an epidural. She can be given a spinal if she needs that, a C-section, or if her labor becomes to the point where she requires a surgical delivery. A spinal is a better form of anesthesia for this. She can get a pudendal paracervical, or what we call a saddle block, excuse me, which numbs the lower nerves by the perineum. She could be given a local, which is a local injection of medication to like the perineum, the labia, specifically if she's starting to tear or needs any kind of repair or episiotomy there. And then a general anesthetic only in cases of emergency. General anesthetic can be very dangerous to the baby. It can respiratorily depress them very quickly. So we really avoid general anesthetics at all costs unless it is a true emergency and we need the baby delivered as soon as possible and we don't have the benefit of time to put in an epidural or a spinal. In intrapartum procedures, we want to make sure we're interviewing the patient with her pregnancy history, her health history, what's going on in this current pregnancy, any medications she may be on, allergies, or any complications during this time. We do a maternal assessment, including vital signs and pain score, and we check her labor status by doing a cervical exam. We're looking for dilatation, effacement, and station, as well as possibly doing a bedside ultrasound to confirm position of the fetus. We also want to do a fetal assessments by placing the external fetal monitor to assess the fetal heart rate and the contraction pattern. We want to assess the status of her membranes, whether or not they're still intact or if her water has ruptured. We can do a Leopold's maneuver to feel the fetal presentation and position and get a good gauge of how big this baby is. And at this time, we definitely want to provide education and support. So when we do a Leopold's maneuver, this is the physical assessment done to determine the presentation and position of the fetus. It can also aid us in locating where those fetal heart rate sounds are and where to place that monitor over. So we want to palpate the uterine fundus, distinguishing between the cephalic and the breech positions. We put our left hand on one side of the uterus. We palpate the opposite side with the right hand to determine where the fetal back is versus the arms and legs. And then we palpate the suprapubic area to find the presenting part and whether or not it's engaged. So this is an example of the Leopold's maneuver. So using these hands to discover where the butt is, the spine, the head, where the legs are. This is the part where you're feeling where the presenting part is, what it is, and if it's engaged in the pelvis. We give labor support by either helping them breathe, and some couples will go to Lamaze classes and do breathing that way. We do comfort measures like massage or positioning or pain meds. And positioning can be standing them, sitting, walking, rocking, lying on their side, leaning forward, going on their hands and knees, or squatting. Any of those positions can help with pain as well as help aid the descent of the fetus into the pelvis. We want to make sure we're educating and that we're their advocates. If they have a birth plan or personal preferences, we want to try to get them as close to their ideal birthing situation as possible, as long as it's safe for both mom and baby. Fetal oxygenation is vital during labor. So oxygen and nutrient-rich blood from the mom that's traveling through the placenta, through that spinal arteries to the baby. And remember that CO2 and those waste products from the fetal blood are then in turn passed to the maternal blood for her to eliminate from her body. So during labor, contractions can cause temporary blood flow disruption or a compression of the spinal arteries from the mom through the placenta to the baby. So when this occurs during those contractions, babies rely on a good oxygen reserve that is from the placenta, fetal erythrocytes, and cells until the contraction relaxes and new, fresh, oxygenated maternal blood returns to the fetus via space. In electronic fetal monitoring, we can either do this continuously or intermittently, depending on what phase of labor she's in. This is interpretive, and we use descriptive terminology to describe what's going on. So when I say it depends on the phase of labor, in early labor, they don't have to necessarily be continuously monitored. You can have them walk around or move around and occasionally listen to the heart rate. As they get into more active phases of labor, and if they have medication like magnesium sulfate or Pitocin, then they are required to have continuous monitoring. So in the external fetal monitoring, we use a toco transducer and an ultrasound. And we put those on externally, so on the abdomen. And if we were to do internal monitors, we can measure them. The toco transducer is what measures the contractions, and the ultrasound monitor is what measures the fetal heart rate. So that's how we're determining the two. Those are both external and placed on the abdomen. If we wanted to use an internal monitor, we can use something called an intrauterine pressure catheter, or an IUPC. That's an internal monitor that measures contractions from the inside of the uterus. Or if we wanted to monitor the heart rate internally, we can use something called a fetal scalp electrode, which is placed on the baby's head to get heart rate. So remember that with these internal monitors that they are invasive and that they do increase the risk of infection. but we do use them if we need a more accurate fetal heart rate or contraction monitoring, or if we need to do other procedures like an amnio infusion. This does limit, there is limitations on maternal mobility once these things are in. She may not be able to walk around or go into the bathtub if she chooses to. We do offer telemetry monitoring for ambulation, but that is somewhat limited as well for where she can walk with the unit, within the labor and delivery unit, and still pick up the fetal heart rate and the tracing. When we're evaluating the external fetal monitoring, we're looking at the fetal heart rate, which the average baseline should be between 110 and 160 beats per minute. If they fall below 110, it's considered bradycardic, and if they are above 160 beats per minute, it's considered tachycardia. The next thing we're assessing in the fetal heart rate is the variability, or the amount of fluctuations of the heart rate baseline. If there is no fluctuation or absent, we would call that an absent variability. This is never a good sign and could show that the baby is having problems with fetal perfusion, oxygenation. If you have minimal variability or minimal fluctuation in that heart rate, less than 5 beats per minute, this can be a concern, or it can also be explained. If mother took medication, like a pain medication, this can cause some minimal variability for a short period of time as the medication crosses to the fetus. It can be caused by a mom being on a medication like magnesium sulfate. It can also occur if baby's in a sleeping pattern. When babies sleep, they don't sleep for longer than usually a half an hour. So really you should see this minimal pattern start to get back up to a more moderate variability after about 30 minutes. Moderate variability is when the fetal heart rate fluctuates between 6 and 25 beats per minute. This is the ideal. This is what the normal fetal heart rate that we like to see. And then marked variability is if there's a fluctuation that's greater than 25 beats per minute. And sometimes this can indicate that there's a cord compressed or wrapped around somewhere causing these major fluctuations. The pattern of rate changes from the baseline are called accelerations or decelerations, and we use an acronym called VEAL-CHOP to try to remember this. So you guys can use this when you're trying to remember on how to figure out what types of decelerations and interventions we have here. So VEAL-CHOP is a way that we take the VEAL part and we talk about the different types of the different types of fetal heart rate movement, whether it's an acceleration or a deceleration. It could be a deceleration that is a variable. It could be deceleration, which is called early deceleration, or it can be a deceleration called a late deceleration. Or it could go in the opposite direction and go up and be called an acceleration. And then the CHOP part is telling you what's going on with the baby, which is causing this type of variation. So in a variable, it means the cord is being compressed, either because the cord is wrapped around the neck or a body part, or it's being compressed against the uterine wall and the baby during a contraction. It causes a variable in the heart rate. An early deceleration occurs when the head is being compressed in the birth canal. An acceleration occurs when the baby is doing well. So accelerations are okay in this matter. Accelerations tell us that the baby is having good perfusion, good oxygenation, and is responding to the stress of the contraction well because of the good oxygen reserve they have in their placenta. And a late deceleration tells you that there's something wrong with the placenta. So there's placental insufficiency. So when we look at these periodic patterns in fetal heart rate, we're going to start with accelerations. So this is a temporary increase of the fetal heart rate of at least 15 beats per minute higher than the baseline and lasts at least 15 seconds long. This is a reassuring sign of fetal well-being. It tells us that there's a good central nervous system, a healthy placenta, and we are not acidotic. This occurs spontaneously, or it can occur with fetal movement, scalp stimulation on the fetus's head by an exam or a finger, or contractions. So this is what an example of an acceleration would look like on a tracing paper. This is the baseline as it comes across. The acceleration goes up, at least 15 beats difference, lasts for at least 15 seconds, and returns to baseline. The next types of periodic pattern changes are decelerations, and there are 3: variables, earlies, and lates. A variable is a fetal heart rate deceleration that has a V or a W shape to it. It's associated when the cord is compressed. It can be prolonged, where it can last a long time, or be recurrent, and this can lead to acidosis. It can occur when there is oligohydramnios, meaning not enough fluid around the baby, which causes the cord to either prolapse or get compressed. It can occur if the cord is wrapped around the fetal neck or body. And the interventions include maternal position change, IV bolus, or an amnio infusion. This is an example of a variable. So notice that this is the fetal heart rate baseline. The heart rate drops and then returns to baseline rather quickly. So not only do variables have a significant V, or what we call a W shape to them, like a quick down and quick up, they have a very short nadir, which is the lowest point of the drop of the heart rate, should last less than 10 seconds. It's a quick drop with a quick return. And it can occur spontaneously, with or without contractions, before or after contractions, or during, so they can occur at any time. If they're having recurrent variables or prolonged variables and we're worried about that acidotic state, treatments can be an amnio infusion. And this is a method in which isotonic fluid, usually normal saline, is instilled into the amniotic cavity through the IUPC, or that intrauterine pressure catheter that's placed to figure out contractions. This can also be used to thin meconium if a baby has had meconium passed in the amniotic fluid, and it also prevents or relieves cord compression. So you would put this internal monitor in, you would hook this to the normal saline, and then the normal saline would be inserted into the amniotic cavity, and it would cause there to be less pressure or compression on that cord. The next type of deceleration is an early deceleration, and this occurs with fetal head compression. So this drop occurs at the peak of the contraction and often mirrors what the contraction looks like. It's a vagus nerve compression that will slow down the fetal heart rate due to the fact that the fetal head is being compressed. It occurs with fetal descent into the pelvis and with pushing, and it is not associated with fetal compromise. It's not a bad thing to have these, it's an expected finding. So this is an example of an early deceleration. Again, your fetal heart rate baseline is in between the contractions. Notice as the contraction goes up, the fetal heart rate goes down. The nadir is identical at the acme, or the peak of the contraction, and then the heart rate starts to return to baseline as the contraction comes down. So it's a gradual. Notice this is not a V or a W shape, it's a U shape. It's a gradual descent, takes a little longer in the nadir, and a gradual return to baseline. So that's an example of an early deceleration. Not a lot of intervention necessary. I would say at this point you might want to just check your mom's cervix to see if she's getting ready to deliver, because you would expect to see these findings as that head is getting further and further into the pelvis, and so she may be closer and closer to delivering. A late deceleration is uteral placental insufficiency, or any kind of impaired exchange of oxygen and waste products in the placenta. So this drop occurs after the peak of the contraction, which makes it a late, and it can lead to fetal acidosis. So the causes can be acute, meaning mom's experiencing hypotension, or she has a contraction tachysystole, meaning that she's contracting one after the next with no rest time in between. This can cause there to be a disruption to the oxygenation to the fetus. Remember, the baby relies on mom to have that resting interval between contractions so that fresh oxygen-rich blood can return to the baby. So if it's not getting that rest in between, that can cause some fetal distress. Or it can be a transient reason. Mom has maternal hypertension or diabetes that could affect the vessels and how well that baby's being perfused. Fetal reserves will eventually deplete if the baby continues to suffer with these late decels. Interventions will be oxygen by face mask, not by nasal cannula, an IV bolus, a scalp stim where we actually do a vaginal exam and scratch the top of the baby's head with our finger, and that should cause a reaction to the heart rate to spike up. We can do a maternal position change. We can discontinue Pitocin or help to relax that uterus. We can do a vaginal operative delivery if we need to do this eminently by using a forceps or a vacuum, or we can move right to a cesarean delivery. And these are an example of late decelerations. Notice they look similar to an early deceleration as far as the gradual descent, the long nadir, and then the eventual return. But notice where their drop is after the peak or the acme of the contraction. So they're not mirroring them in this case. As the contraction's on its way down is when the heart rate starts to drop and then return. There's also a pattern called sinusoidal fetal heart rate pattern, which is defined as a pattern of fixed, uniform fluctuations of a fetal heart rate that creates a pattern that resembles successive geometric sine waves. It's frequently described as undulating and smooth, and is characterized by the absence of variability. So in this case, this baby would have zero fluctuations in the heart rate. This is associated with fetal or maternal hemorrhage that cause severe fetal anemia or hydrops fetalis, which we talked about earlier when we talk about blood incompatibilities and one of the side effects of a blood incompatibility. So this is an example of a sinusoidal. So notice that it's this rhythmic, wave-like formation. There's no variation in between these fetal heart rates. There's no fluctuation. That's a sinusoidal pattern. Now, I do want to just mention that you can have something called a pseudo-sinusoidal, which means false sinusoidal. And there are some medications, specifically like narcotics, that can mimic sinusoidal, but only for a short period of time. So if you see this, what looks to you like a sinusoidal pattern, and A, you know you've given your mom some sort of narcotic, or B, you're able to do a scalp stim or a position change and kind of knock that baby out of that pattern, then you know it's a false sinusoidal pattern. So when we're looking at the tracings, we give them categories. So a category 1 tracing means that we looked at this fetal heart rate tracing and it's normal. It's not associated with any kind of fetal asphyxia. So we know our baseline is between 110 and 160. We've got good moderate variability. We don't see any late decels or variable decels. We could possibly have early decels, but remember, that's not a bad sign. And we could possibly have accelerations or not have accelerations. It doesn't make a difference. It still would fall under category 1 tracing. A category 2 tracing means that this is indeterminate, meaning that we can't say it's bad, but we can't say it's good. We're not quite sure. This could include a wide variety of possible things that don't fit into either category 1 or category 3. And then in category 3 tracing, these are abnormal tracings that are indicative of a hypoxic risk to the fetus and possible acidemia. So we don't see any baseline variability. So that's that absent baseline variability, or the presence of recurring late decels. Remember, lates are the bad ones, or variable decels. We can see a pattern of bradycardia or even that sinusoidal pattern that would fall under category 3 tracing. Some intrapartum complications that can occur is a dysfunctional labor pattern where the contractions are either hypertonic or hypotonic contractions, meaning that they're not strong enough or that they're too strong or too frequent. We can look at premature rupture of membranes, which is the breakage of that amniotic sac more than 1 hour before the onset of labor. So your water breaks, but you don't start contracting. It doesn't kick your body into labor. That's a premature rupture of membranes. And then obviously preterm labor, which we discussed before. Emergencies in the intrapartum unit would result when there are placental abnormalities, if there's a prolapsed umbilical cord, if there is a uterine rupture, a uterine inversion, an amniotic fluid embolism, or any kind of trauma. And we're going to go more into that when we talk about high-risk delivery in the next lecture. Different antepartum fetal surveillance tests that we can do is a non-stress test, a contraction stress test, a vibroacoustic stimulation, or a biophysical profile. And we talked about some of those tests earlier in the antepartum lecture. When we talk about the non-stress test, this is a non-invasive prenatal test to check the fetal well-being, that the fetus is getting adequately oxygenated. We're looking for those accelerations in the heart rate with fetal movement, and we know that if they have at least 2 of those fetal heart rate accelerations within a 20-minute period of watching it, and remember, in order for it to qualify, it has to be 15 beats a minute above the baseline for at least 15 seconds, then we can call this non-stress test reactive, which means reassuring that this baby is doing well in this intrauterine environment. A non-reactive non-stress test means that it's non-reassuring, that it didn't meet this criteria. Maybe it had not enough accelerations or none at all. Maybe the accelerations it had didn't meet criteria with how high it went up or how long it lasted. Or maybe there were decelerations noted within that 20-minute period. All of those things would say that it was non-reassuring and would require further evaluation. So this is an example of a non-stress test. You place a mom on the external monitors. You watch the tracing for 20 minutes. You have her press a little button where she marks fetal movement that she feels, and you try to correlate it with the different accelerations. And if you have a tracing that looks like this in 20 minutes, you have a reassuring reactive non-stress test that the baby is doing well. Another test that we can do, or another thing we can do, is called a vibroacoustic stimulator, which is a vibration sound that we place over the maternal abdomen to confirm or shorten a non-stress test. Meaning that if I have a non-stress test going and I'm not getting what I need, I'm not getting those accelerations or that fetal movement, maybe the baby's sleepy, I can do this short little vibroacoustic stimulator, which is just noise. It doesn't affect the baby, but it does cause the heart rate to jump up, and it gives them both fetal movement and accelerations in response to the sound. And this is another way we can get that fetal non-stress test to become reactive or reassuring. Another test we can do is a biophysical profile, which I know we talked about earlier in antepartum, where we use that ultrasound to do those five parameter predictions of fetal well-being. We can include this with our non-stress test findings. And in addition, we'll look at that fetal breathing movement, the gross fetal movement, the amount of amniotic fluid, the fetal tone, and then we get that final score, hoping we get the 8 out of 8, which is a good finding. And again, fetal well-being is reassured. The other thing we can do is assess amniotic fluid volume by measuring the amniotic fluid index. And remember, we're measuring those 4 pockets of fluid around the fetus, and we do this via ultrasound. We want it to be between about 8 to 18 centimeters, and this can vary with gestational age. And remember, again, the low fluid around the baby is considered oligohydramnios, and the high fluid around the baby is considered polyhydramnios. And these are just 2 videos that I'd like you to watch when you get the time to do it. One is showing you a vaginal delivery, and the other one is showing you a cesarean section delivery. Hopefully you guys will be able to experience this in your clinical rotation and see one, if not both, of these types of delivery. But if you don't get that chance, take a look at these videos, and it'll help you kind of put some of these things that we've been talking about together. Thank you very much.